Thank you so much for the chance to come and talk with you. I don't have any slides, so I'm just going to talk for a couple of minutes about the work that we're doing. I'm a family doctor, as Jillian said, mostly have worked in the last 15 years as a frontline family doc in Camden, New Jersey, which is right across from Philadelphia. It's in New Jersey, and it's a 9 square mile city that's one of the poorest cities in the country. It's also one of the most dangerous cities in the country. We tried a wonderful social experiment about a year and a half ago of laying off our entire police department. First, we laid off half of them, and crime spiked, and then we decided that wasn't a good idea, so then we laid them all off, and they reapplied for their jobs to be county metro officers. It's an interesting place in that it's only 9 square miles, and we have 3 emergency rooms and 2 hospitals. One of the hospitals is a large academic health center. And about 13 years ago, began to form a membership nonprofit. And if anyone's ever worked in or tried to run a membership nonprofit, they're very unruly organizations. And my members are 3 hospitals that are highly competitive and would like to put each other out of business, 2 federally qualified health centers, primary care offices, behavioral health, addiction, and we have patients on our board as well. We re-elect our board, executive committee, and officers every year. And our vision is try and be the first city in the country to bend the cost curve and improve quality. So we've been at this a long time, and it's very, very, very hard work. We have about 50 staff at this point, and we're very focused on healthcare delivery. So we are not doing public health work, so we say no to a lot of things. We're not doing primary prevention, which is keeping healthy people healthy. We're not doing secondary prevention, which is keeping people with mild versions of chronic illnesses healthy. We're exclusively focused on tertiary prevention. So that's keeping people who've had bad events, helping them recover, rehabilitate, and reintegrate back into society. Much of our work was really driven out of a database that was built as a homegrown database with claims data from all 3 local hospitals. And when we assembled that database, we ended up with now about 12 years of claims data from 3 local hospitals with all the identifiers, name, address, date of birth, date of admission, charges, receipts, combined into 2 $50 hard drives with open source encryption, password protection. We use Microsoft Access, a desktop computer, and ArcView GIS to do all the analysis. We're obsessed with outliers, and our data belief is that Epi and biostats have kind of ruined data, and that Epi and biostats is obsessed with averages and means and with the curve. We want to know about the long, messy tail of data. So it's the nonlinear, messy part of the data set that tells you a lot more about the data. So we've spent a lot of time exploring the long tail in Camden, and way out on that long tail is someone who went 324 times in 5 years, a patient who went 113 times in a year. 1% of the patients are 30% of the receipts. So we have the receipts from each hospital as well. So we've spent 12 years sort of chasing those folks around and getting to know them and beginning to understand the dynamics in the system. And those folks tell you a lot about what's broken in healthcare, and we've really built our intervention and our organization one patient at a time in response to what we've seen. So we run a health information exchange, which is real-time demographics, labs, radiology results, and hospital discharge summaries, because you need to know who is running around where, when, in order to intervene. So we use that data day by day, moment by moment, to go right up to the hospital. Our staff have both EHR access to all the hospitals, they have badges for all the hospitals, and go right up, meet the patient at the bedside, chase them, follow them out of the hospital, go to their house, go with them to their primary care appointments, specialty appointments, and wrap around them for about 90 days. That's all modeled off of ACT, which is a model in behavioral health. It's modeled off of PACE, which is a program for high-risk geriatric patients, off of the nurse-family partnership. A whole variety of engagement models is what we've modeled this off of. We're also deep inside of primary care offices, rethinking how you deliver care, where we believe that the patient-centered medical home is really 1 inch deep on 2,500 patients, and we need to go 1 mile deep on 10 people, and getting an office to do that's a very, very different workflow. So spending a lot of time thinking about what that looks like. Our belief in Camden and what we've learned is that you need 3 things to fix anything in healthcare, and they're very hard to align. You need engagement, and it's not in the way we learn engagement in medical school or in health professions. It's motivational interviewing, it's harm reduction, it's change management, as I already mentioned, it's community organizing, it's coalition building, And frankly, all of those things have very facilitative frameworks in the way they use language. They break hierarchy down, both at the patient level, at the sort of system level, the community level. Data, and we use data in very, very different ways, as I've already alluded to. We're much less interested in averages and more interested in outliers. We are not interested in predictive modeling. Predicting rare events is not possible. We're much more interested in surveillance, which means responding in real time to emerging patterns with clear workflow triggers. We're less interested in disease-focused and more interested in complexity-focused. We're not interested in stratification. We're interested in segmentation. So we have all these really very truncated ways of thinking about data in healthcare. And the last piece that we're focused on is redesign. We think that this is systems engineering concepts. So box by box redefine of who does what, how they do things in healthcare. This is moving from craft and guild operations to assembly lines. This is task shifting, delegation, a lot of the things that have been talked about. So engagement, data, and redesign. And it's easy to get one of these things. You can sometimes get two, but getting all three of them is extraordinarily difficult. Our organization, unfortunately, has had to step out of Camden and have had to do a lot of state and national work, and it's really not what we wanted to do. But we found, as many people have found, that you can't fix healthcare without reaching outside of your local community. We worked on legislation about 3 years ago that was signed by Governor Christie back in 2011 to create a New Jersey Medicaid ACO demo project, which dealt with antitrust by invoking a Supreme Court decision called there's a hole in the Sherman Antitrust Act called the State Action Doctrine, which says that states can stand in the middle of things, which is why an attorney general can stand in the middle. So we use that in this model. We've been doing a lot of advocacy work, so our three frameworks in our organization are to build a movement, to build a field, and to build the lab. So the lab is in Camden. The movement is the advocacy work that we're spending a lot of time on at the state level. And the field is really the field of population health, which my own opinion at this point is that the field of population health doesn't exist. It's not a field, because a field has clear frameworks and clear terms. So I'll give you an example. The word care management really is a meaningless word. And it's kind of at the center of population health. How can you have a word that's so meaningless be at the center of a field? So care management means anything from a nurse in a cubicle at a Medicaid health plan calling homeless people with no phones to a health coach in the Camden Coalition banging on doors and visiting people in the most dangerous city in the country. For a single word to be able to stretch across that diverse of activities shows that the field of population health doesn't really exist yet. It's often described as something between public health and healthcare, but I think when it finally matures, it will have psychology, sociology, anthropology. It'll pull in systems engineering, systems dynamics, economics, a much more complex field than we've even been able to scratch the surface of at this point. So our definition of population health is better care at lower cost for everyone every day. Better care at lower cost for everyone every day. So I want to close out by just talking about some of our workforce challenges, and they're enormous. Like we've had to kind of home grow, much like we've had to home grow our data system, we've had to home grow our workforce. So one of our favorite projects is AmeriCorps, and we use currently 10 AmeriCorps volunteers a year. We're growing up to 15 that we train as health coaches. And these are college-educated kids like Teacher America who get trained up, paired up with our nurses and our social workers, and get sent out as the front line of our intervention. So it turns out that a huge amount of what we do, and frankly, I think everywhere in healthcare could be delegated. So we have found a lot of the care coordination work we do can be delegated to them. They're all going to med school, nursing school, and social work schools. We have 5 of them going on to med school. So they're kind of my secret weapon. We've given them deep programming that will turn on when they hit 3rd year. So unbeknownst to the AAMC, I have sleeper cells infiltrating med schools all over the country. The other is a population health fellowship, which has been supported by the Aetna Foundation. And it's been for 2 years in a row. We've had 2 population health fellows that are board certified family docs that spend a year with us. And they're doing a super utilizer hotspotting fellowship where we give them a messy, ambiguous problem, and they spin in circles for a few months, and then they slowly start to figure it out. So it's very much experiential learning, and they learn to begin to align data, engagement, and redesign to solve a problem. So it's been a lot of fun to watch them grow and develop. And there aren't going to be enough clinicians that can be clinical champions for population health. So it's really going to be an important new category of people to grow. The whole world of CHWs is a mess, and it's been a mess for us. And we've been very unsatisfied with the models because for our category of patients, the top 1%, the normal model of CHWs is really built for primary prevention and secondary prevention. Our folks terrify the typical community health worker. And what can end up happening is you send out CHWs to people who are like, one step out of the grave, who are top 1%. And, the CHW says, oh my God, you look really sick, go to the emergency room, So it's like you've actually built an antenna to go out and, send your sickest patients to the hospital or more. Our folks are really terrifying. The sickest of the sick are really complex. So we have instead retrained medical assistants and LPNs and kind of retasked them for this because we found that people who've spent a lot of years in medical offices, as an MA or an LPN, you can kind of retask them, retrain them, and then they're not scared of sick people because they've been working with sick people. They're also not scared of doctors, which is a big part of the accompaniment of our patients. It's important that they not be intimidated by the healthcare system. The other pieces of the workforce, there are not enough data people, informaticists in healthcare. Biostats and epi is a really bad training for what we do. Getting a master's in computer science isn't I don't know there is no master's degree that trains people to prepare for what we do. So we end up sort of training them on the fly. What we need are generalists, not specialists. We need people who can use multiple different tools, and they don't need to be so deep in any of the tool sets. So we really prefer generalists over deep specialists. I don't need the world's greatest statistician. I need a person who can one moment sit with Microsoft Access, the next moment can play with a visualization software, the next minute can explain something and actually talk about something to people, can put a PowerPoint together. I mean, I need a generalist, not a deep specialist. And we've been spending a lot of time in our organization trying to build out some curriculum for this. And the curriculums for a lot of the things I've just talked about don't exist yet. So we have something called cross-site learning, which is collaborating with sites around the country. There are about 50 sites that we found doing superutilizer work around the country. We work directly with about 15 of them and have begun to really figure out what's the wrong way to do this. I don't know that we know the right way to do it, but we know that 15 ways not to do it, so we can keep people from making those mistakes. So thank you very much. Look forward to the panel.